Do patients really need to see us every 6 months, or is that just a dental tradition? For decades, see your dentist twice a year has been drilled into the public mind. It's in commercials printed on toothbrush boxes and repeated by every hygienist since childhood. But if you stop and think about it, where did that even come from? Who actually decided that every human mouth on the planet needs to be professionally cleaned every 180 days? Here's the surprising part. That 6-month rule wasn't born from science at all. It came from a marketing campaign in the 1950s created by toothpaste companies, not dental researchers. The slogan caught on, it sounded responsible, and over time it became the cultural norm. But we never stopped to ask, does it actually make clinical sense? So today we're asking that question head on. Do patients really need a 6-month recall? Or is 12 enough? When you look closely at the biology, the tradition kind of starts to crumble. In adults, both dental caries and periodontal disease are typically slow progressing conditions. Cavities don't form overnight, and attachment loss doesn't happen in a matter of weeks. These are diseases of time, biofilm, and behavior. If a patient has a stable mouth, brushes effectively, flosses, uses fluoride, their curve flattens dramatically. For those patients, the difference between 6 months and 12 simply isn't biologically significant. Let's start with the biggest study on the topic, Clarkson and colleagues, and that's published in the Cochrane Database of Systemic Reviews. This was updated in 2023. Over 2,300 adults across 51 general dental practices were randomly assigned to 3 groups: 6-month recall, 12-month recall, or risk-based recall determination by the dentist. They were followed for over 4 years. The results were pretty clear. There was no difference in cavities, gum health, or quality of life between any of the groups. Zero difference. The patients who came every 12 months were just as healthy as the ones that came every 6. And the kicker is they spent significantly less money, and the dental team saved valuable chair time. That study alone challenged decades of convention, but it doesn't stop there. Those findings formed the foundation of the updated NICE guidelines CG19 in the United Kingdom. That was released in 2024. NICE reviewed all available evidence and stated that very directly, there is no clinical justification for a universal 6-month recall. Instead, they recommended recall intervals anywhere between 3 to 24 months based entirely on risk, caries experience, periodontal stability, systemic health, and other lifestyle factors like smoking or their diet. So that's the key, risk. The era of one-size-fits-all recalls seems to be pretty much over. The science tells us that the frequency of preventative visits should match the rate at which disease might realistically develop in that specific patient. Now, let's bring this a little bit closer to home. A large population study that was published in the JADA magazine in 2021 analyzed more than 10,000 adult patients in the United States. They found that 6-month recalls did lead to slightly fewer restorative needs, but only for patients with high caries risk or poor oral hygiene. For healthy, low-risk adults, there was not any measurable benefit. And a 2019 randomized clinical trial published in the Journal of Dentistry reached the exact same conclusion. After 3 years, there was no difference in decayed, missing, or filled teeth, or in the periodontal attachment loss between 6-month, 12-month, and risk-based groups. So what was the difference? Well, the cost. The patients and practices both saved money when intervals were extended. Now, even large real-world cohorts, like a 2023 study in BMC Oral Health, it found that over-recalling low-risk patients increased costs and workload without improving any outcomes. So when you really add it all up, between Cochrane, the NICE, the JADA magazine, Journal of Dentistry, the conclusion is consistent and unshakable. The average healthy adult coming in every 6 months just doesn't really necessarily make them healthier. Now, let's pause and we can address the elephant in the operatory, the hygiene shortage. Right now, almost across all of the US, every dentist is struggling to hire hygienists. Many hygienists retired during COVID. Schools can't graduate enough replacements, and the pipeline simply can't keep up with the demand. The result? Well, vacant hygiene chairs, overloaded providers, and long recall backlogs. So what are our options? Well, one, we could lower graduation standards and allow expanded duty assistants to perform more preventative services. 2, reimagine dental hygiene as a trade school or an accelerated program so that we can train and replace more providers faster. Or 3, take a hard and honest look at the services, which ones are truly necessary, and how often they're needed. I'm looking at this completely objectively. Just through the lens of what the evidence says. Now, the reality is that the blanket default of every 6-month cleanings is not strongly supported by research. Now, don't misunderstand me. If a patient is systemically compromised, diabetic, on multiple medications, active periodontal conditions, or very high risk, then they should absolutely be seen every 3 to 6 months. The same goes for patients that have extremely high caries risk or poor hygiene or heavy plaque accumulation. They need that professional maintenance. But there's a huge portion of the population, healthy, motivated, low-risk adults, who simply don't need that frequency. And keeping them on 6-month recalls out of tradition or habit isn't an efficient use of our resources. Now, here's another layer. From a business standpoint, those healthiest 6-month patients are often the least profitable group in hygiene. They take up prime chair time, require minimal scaling, and generate little in additional treatment. Meanwhile, high-need patients who could benefit from more frequent care sometimes just can't get in because hygiene schedules are packed with routine low-risk recalls. That's not really efficiency, that's just inertia. Now, there might be a win-win solution here, treating people based on their risk factors and recall needs rather than just a one-size-fits-all rule. It's probably not what hygienists or even some dentists want to hear, but that's what the research says. So let's translate this into action. For most adults, 12-month recalls are just as effective as 6. The key is individualization. High-risk patients, active decay, bleeding gums, smokers or diabetics, they need 3 to 6 month intervals. Moderate risk patients might stay around 9 months or so. Low risk patients can safely extend to 12 or even 18 months without harm. Think of what that could do for your practice. A risk-based model means that you're matching clinical need to clinical time. You're freeing up hygiene capacity, reducing burnout, and improving access for patients who actually need more help. It's not just better science, but it's probably better business too. And patients love the logic behind it. When you tell them, hey, we're customizing your recall schedule based on your actual oral health, they feel like they're getting personalized care. It builds trust. It reinforces the idea that you're treating them, not just the calendar or just treating them like a number. So how do you make it work? Well, you can just start small. At every recall exam, perform a quick risk assessment. Caries activity, periodontal status, systemic conditions, and home care habits, and even fluoride exposure. Document it and then assign a recall interval right there in the chart. Use your practice management software to create recall codes that are tied to these risk levels. Low risk could be 12 months, moderate 9, high could be 3 to 6. Train your front desk and hygiene team to explain the reasoning. You could say something like, your recall interval is based on your personal oral health and risk level. That's how we make sure we get exactly what you need, not more, not less. And you'll be probably amazed at how well patients respond when they understand the why. Now, here's another upside, cost effectiveness. In the Cochrane review, risk-based and 12-month recalls not only maintained oral health, but they reduced the cost per patient and increased overall efficiency of their care delivery. That's a great combination. Better alignment with evidence and better alignment for the needs of the people. From a public health standpoint, adopting risk-based recalls also means that we can redirect limited hygiene capacity toward underserved or high-risk populations. So if low-risk adults only needed a checkup once a year, that opens up appointments for those who truly need them more frequently. It's a great use of the workforce, and it could help stabilize access issues nationwide. Now, will some hygienists worry this devalues their role? Possibly. But in reality, it kind of elevates it. It shifts hygiene from a repetitive schedule of routine cleanings to a higher value, diagnostic, and risk management role. Hygienists become educators and disease prevention experts, not just frequent recall machines. That's where the profession needs to go. So to wrap this up, the science is pretty clear. The workforce reality is undeniable, and the opportunity is right in front of us. The 6-month recall is tradition, not evidence. The future of dentistry is risk-based care, personalized, data-driven, and efficient. Modern dentistry isn't about doing more, it's about doing what matters the most. Now, let's keep working on this and working together to make dentistry fun, fulfilling, and rewarding. Subscribe so you don't miss the next strategy, and I look forward to seeing you soon.